here. Started recording. Let's move on to point. Perfect. All right. I hope everybody's having a lovely day so far. If you live in the Alabama area, it seems like a beautiful day, although I guess it's going to get below freezing tonight. Go figure. Keeps us on our toes, I guess. All right, go ahead and play. Cool. So before we get started, do you have any questions about what we learned last time or about anything else in the class? Go ahead and type it into that chat box we've got going on. So while I'm waiting for any questions to come in, I found out I can determine what percentage of class has filled out the SIEs. I can't tell who has and who hasn't, but I can tell the percentage. Right now we're at about 20 some odd percent. And I think the agreement I made with y'all is if we can get to 75% or higher, I will give everybody in the class an extra point or two. And so I'm going to, per the university's recommendations, set aside time at the end of class today for y'all to actually fill out your SIEs. If y'all are watching this via recording and aren't in class currently, please do take the rest of that time to fill out those SIEs. They do help me, they help the university. And if we get enough of y'all to do it, everybody gets some extra credit points. So life is good there. No real reason not to fill it out. All right, I am not seeing any chat questions, but if you do have them, go ahead and fill them out. Where can we find the SIEs? So if you go onto Canvas, click on the course. There should be on the left-hand side where you would navigate to the different things like assignments and files, etc. There should be a hyperlink there for SIEs. So if you still can't find it after that, let me know and we can get you in the right point in the right direction. All right. So if any other questions come up, do type them into that chat box and I will answer them as they come up. Today we are talking about drugs, but we're going to start with a fun fact of the day, and this always blows my mind. It's hard to believe, but the cigarette lighter was invented before the match. Go figure. All right. So, skip some? No. All right, so today we are talking about drugs, and we are predominantly going to be talking about drugs of abuse, not necessarily psychopharm drugs. And so when we're talking about substances, all we mean is that it's a chemical that alters a person's mood or behavior. It can be smoked, injected, drunk, inhaled, swallowed, the whole like. And so this includes both legal and illegal drugs. So legal would be caffeine, nicotine, morphine, Ritalin, SSRIs, any sort of prescription drugs. Illegal substances would include things like cocaine, methamphetamine, marijuana, etc. You can venture into illegal use of legal substances with drugs of abuse like opiates, so painkillers, things like that. But we're largely drawing this distinction between legal and illegal. Now I realize there is, certain idiosyncrasies about state laws versus federal laws about things like marijuana, even things like psilocybin, so mushrooms, known colloquially, in, for example, the city of Denver, are legal, the rest of the state illegal, things like that, but we're going to draw the distinction primarily at the federal level here. And so when we talk about substance use, not just substance abuse, but substance use, it's important to keep in mind the concept of tolerance. And so the tolerance is just the extent to which an individual requires larger and larger amounts of that substance or larger doses in order to achieve its desired effects, or the extent to which an individual feels less of the effects after using the same amount of a substance, right? And so um, if any of y'all drink coffee or caffeine, the first times you drank coffee or any sort of caffeinated beverage, it probably had a substantial effect on you. However, you build up a tolerance over time such that now 1 cup of coffee doesn't do it for me in the morning. I have to have a couple cups of coffee or else I feel lethargic throughout the day. Similarly with alcohol, I don't really drink, and so now if I have 1 drink, I feel the effects substantially more than I used to in college when I would have a couple drinks here and there. And so you build up your tolerance over time to both legal and illegal substances. That's why smokers tend to smoke more with time. They've built up that tolerance to nicotine. Why habitual drug users will have built up a tolerance to drugs for which that dose may kill somebody who has not used those drugs before. And so when somebody builds up a tolerance to various drugs or substances, there are essentially 2 different uh, types of dependency that we can claim drugs cause. One would be a physiological dependency. And physiological dependency is the actual, physical feeling of need for those drugs, not the psychological, but for example, getting withdrawals. So irritability, shakes, nausea, sweating, etc. And so I don't know if any of y'all have smoked and then tried to smoke, but some of y'all who may have built up that dependency have had these sort of withdrawal symptoms that are very physical in nature. In some cases, there can actually be death during withdrawal. So one of the issues with alcohol dependence is somebody who has developed substantial alcoholism is at risk for actually dying if they were to stop cold turkey. Now that's not the case of you have a couple drinks a night every night and then stop. It's at the more extreme examples, but that's why a lot of these alcohol cessation programs actually need to happen in the presence of medical personnel so they can monitor the individual to prevent this most extreme response to alcohol withdrawals. But there's also psychological dependence. And psychological dependence happens in isolation from physical dependent symptoms, but this kind of psychological experience of needing these drugs. And so you'll often hear people say things like, marijuana isn't addictive, right? There's no addictive principles. And while that seems to be true on the physiological level, there is substantial evidence that on the psychological level, it creates certain levels of dependence, right? You can think about various things that may not even be drugs in your life that have psychological dependence, right? You create kind of a psychological addiction to it. Perhaps, working out. If you don't get the chance to work out, you may have kind of these psychological withdrawals associated with not getting kind of your fix. In this case, it would be a more healthy fix. Now you can take it to the extreme, but a more healthy fix associated with that working out. So you can still have withdrawal symptoms, even if the substance you are using is not physiologically addicting. So at what point does the use of a substance become a disorder? right? We don't say that those who have a drink every so often abuse alcohol, but there are clear cases wherein somebody is said to be an alcoholic or to have alcohol use disorder, right? Their use is no longer within the confines of what we would deem normal, right? When we had the conversation about psychological disorders, we had to kind of pit what is normal versus abnormal. And it largely came down to the disruption of everyday life, normal things in everyday life. And so substance use disorders are this cluster of cognitive, behavioral, and physiological symptoms indicating the individual's use of a substance despite significant substance-related problems. And what would those problems be? Well, it would be things like neglecting work obligations, commitments to family erodes. So you're not, if you have kids, for example, you are not carrying out the expected duties of a parent, taking personal risks such as drunk driving, but also disorderly conduct, right? Actions that are inappropriate or illegal in any capacity. And so it becomes a disorder when the use of the drug or the substance prevents you from acting in what would be otherwise a normal and well-adjusted manner. And so you can think about perhaps even at parties, you may have seen people who act way outside the bounds of what is appropriate when under the influence of alcohol. And this would be an indication that there is, probable cause to think this person has a substance use disorder, right? One of the problems on a lot of college campuses is this sort of binge drinking culture. And it's perceived to be normal because everybody's doing it. But when you take it in isolation, right, all of the negative consequences associated with binge drinking and all of the the additional derelictions of responsibility, etc., it then does kind of venture into, okay, alcohol use disorder, alcohol abuse. But this isn't just limited to alcohol. Obviously, any substance that is negatively impacting these things and others similar to it would be said to be a substance use disorder. So what comorbidity do we have within substance use and psychological disorders, right? And so here on this graph, you see 4 different categories of drugs. You see kind of a catch-all here of any drug, and then percent of people who are using that drug. And so you can see about 10% of people have, I don't know over what span of time, but this is essentially just a baseline, right? Have used any drug. However, when you look at mood disorders and anxiety disorders, you get substantially higher percentages, nearly double that of the baseline population, right? So there is this higher rate of drug use amongst those with mood disorders and anxiety disorders, right? And one of the things we've harped on throughout class is that correlation does not equal causation. So there are 2 different ways you could essentially be looking at it. Well, I mean, there are more than that, I guess, but the 2 most probable ways is either you have this mood or anxiety disorder and you start self-medicating with these other drugs, or use of these other drugs can increase the likelihood of getting mood and anxiety disorder. And so this is, we'll talk about self-medication in just a minute here, but this is one of the issues with people self-medicating, right? They have anxiety, so they drink. The problem is substance use actually increases the instances of unstable mood and also anxiety, right? And so it becomes this kind of snowballing of, you have anxiety, so you drink, your body's response tends to then be more anxiety, so you drink more, etc. And it kind of continues to snowball. And that's why a lot of therapists, when you go in for any sort of mood or anxiety disorder, will ask about your substance use. And very often, some of the advice will be, okay, let's try to scale back the amount you're drinking or smoking, etc., to try to help reduce any of these kind of environmental causes of your, for example, anxiety, in a way that allows us to get on top of everything and stabilize your mood or anxiety levels. So yeah, like I just said, substances are frequently used to quote unquote self-medicate, self-medicate against things like anxiety and depression, but use increases things like anxiety and depression. And so, when I was out in Colorado, there was a lot of conversation about the use of marijuana to treat anxiety and depression. The problem is there is substantial evidence that suggests that marijuana can increase the prevalence of anxiety and depression within an individual, right? And so you get people self-medicating, trying to treat their own depression or their own anxiety with marijuana use. However, that's only increasing their rates of anxiety and depression. Now, this isn't to say for everybody in all cases, but kind of generally on the group level, it does seem to create issues within those psychological disorders. So I'm going to go ahead and pause here. If you have any questions, go ahead and type them into that chat box. All right, I'm not seeing any questions, but if you do have any, please go ahead and finish them up and send them in. All right, so we can think of substances as being into kind of two broad categories: stimulants and depressants. And so stimulants are any substance that activate or have an activating or enhancing effect on the central nervous system, right? And so somebody quickly type into the group chat, what is our central nervous system? What do we think about when we think of our central nervous system? Yeah, exactly. Brain and spinal cord. Yeah, so any sort of activation of the brain and the spinal cord, which is going to give us subsequent activation of, any of this autonomic nervous system, wherein we have our heart rate, we have our respiration, etc. And so stimulants are things that are going to enhance those, increase, for example, potentially increase your blood pressure, but increase your respiration, increase your heart rate, increase your alertness. So things like caffeine, things like Ritalin, but also things like meth and cocaine are all stimulants. And so the stimulants, I mean, the difference between the stimulants and depressants isn't necessarily the feeling they give you. As we'll see in a second when we talk about depressants, you can still have good feelings. Now, frequently, the mechanism by which these stimulants work do tend to give people a sense of euphoria. And that's why so many stimulants can be incredibly kind of psychologically addicting, right? In addition to physiologically, but things like cocaine will give people this overwhelming sense of euphoria. In fact, I've even heard cocaine described as kind of a sustained feeling of almost like an orgasm. And so these stimulants can, at low doses, be really good things for like caffeine. Right? A certain level of caffeine can be a good thing in your life. It can help increase your alertness. If you have young kids, it can help you get through the day when they've been keeping you up all night. However, at really high levels, they can kind of become um, they can have really bad effects, right? So extremely high levels of caffeine, for example, can cause heart attacks, right? And so this is why you saw so many issues in the mid to late aughts, the 2000s, with energy drinks like Red Bull or Monster, of kids drinking a bunch of those and then going and playing a sport, right? And so these kids, these 18-year-old kids, are having heart attacks, things that shouldn't happen to healthy 18-year-olds, because they were ingesting a ton of caffeine, increasing the activation of their central nervous system, increasing their heart rate, all the other tangential effects associated with activating that central nervous system, and then getting kind of an overactivation, over demand on the system, and leading to a subsequent heart attack. That's why things like cocaine can lead to overdoses really easily. That's why people can have heart attacks the first time they use cocaine or meth, things like that. Ritalin at low doses is used to kind of help treat ADHD. Interestingly enough, things like Ritalin, or I'm trying to think of some of the other names for ADHD medicine. I can't think of them right now, but these ADHD medications tend to have different effects on people based off of their need, right? So if there is this biochemical imbalance associated with ADHD, Ritalin is going to help people focus. However, Ritalin in people that don't have ADHD is likely not going to help the focus. It's going to increase that arousal. And interestingly enough, if you look at the effects of Ritalin on those who do have ADHD versus don't have ADHD, it increases performance in those that do have ADHD, right? It helps kind of baseline them and stabilize them. But there's no real benefit for Ritalin or these other ADHD medicines in those that don't have ADHD. But the flip side of that is it results in a essentially flooding of dopamine in the system. And if we know about dopamine, we know that it does increase the feelings, the good feelings associated with various experiences. And so people tend to think they're doing better when they take Ritalin if they don't have ADHD, even though they're not actually doing better, right? So you get this kind of psychological effect that doesn't correspond to reality. So talking about methamphetamine, as with cocaine, abuse is frequently tied to this feeling of kind of euphoria, right? And this is why people are chasing those highs with drugs like cocaine, with drugs like meth. However, it can lead to substantial mood disturbances, incredibly violent behavior, anxiety, confusion, insomnia, severe dental problems, right? This is where you get the whole idea of quote unquote meth mouth. And so if you've watched Tiger King, for example, there are several characters in there that obviously had problems with meth based off of their severe dental problems. And then also heightened risk of infectious diseases. And so this is one of the issues you're seeing right now with the coronavirus is drug users are uniquely susceptible to succumbing to COVID because of the risks associated with doing these hard drugs. And so you will sometimes see on shows like Cops, people who are obviously under the influence of, for example, meth, who do have this very violent behavior, but also confusion and volatile mood swings. Whoopsies. Cocaine is just the powdered version of crack. And so there are interesting use differences between crack and cocaine, although it is virtually the same drug. Crack, once powderized and cut with various other agents, things like flour, but also stump removal and things, other things that get put into cocaine, is what is known as that crack, so the powderized version. It does lead to these feelings of euphoria, believed heightened mental awareness, reduced fatigue, and heightened energy. Um, Cocaine tends to be abused um, in a lot of communities, but where you see really kind of high power financial industries, it's kind of stereotypically associated with that. People who are working these incredibly long hours become addicted to cocaine, in part because it allows them to sustain this substantial, sustained awareness for long periods of time. Like I said earlier, it can result in heart attacks, respiratory failure, strokes, seizures, abdominal pain, nausea, chronic nosebleeds, anosmia, severe bowel gangrene. So that would be bowel decomposition, right? Your system literally starts decomposing. Um, you can have um, substantial changes in the actual structure of your nose, such that long-term cocaine users, because cocaine is almost exclusively snorted, can get deterioration in their nose, which does lead to these chronic nosebleeds. And so you'll have people who are recovering cocaine users sometimes have to go and get plastic surgery on their nose to kind of create a new rigid structure in their nose to deal with the deterioration associated with use. You then have hallucinogens, which are just these substances that create kind of these abnormal perceptual experiences, leading to hallucinations, which are usually visual in nature, although there are instances of kind of auditory hallucinations, haptic hallucinations. Um, and this includes drugs like LSD, which stands for lysergic acid dithylamide, peyote, psilocybin, known as magic mushrooms, PCP, and ecstasy, also sometimes called MDMA. And so hallucinogens are really kind of these mind-altering substances. It's not just giving the feeling, the good feeling, the relaxed feeling that you may get with depressants, or kind of this heightened awareness associated with stimulants, but it is changing one's kind of actual perception of their environment, of their world. One of the long-term consequences associated with hallucinogens is it actually can increase your rates of developing things like schizophrenia. I don't think we know the mechanism behind it, but increasing or use of these hallucinogens seems to trigger something in people's brains that makes them more likely to struggle with the dissociation between reality and hallucination. Let's see. No, I don't have anything in there. All right, I'm going to pause real quick. If anybody has any questions, go ahead and type them into the group chat box there. The hallucinations are frequently so vivid and often of kind of a spiritual nature that some of these drugs have been historically used in religious ceremonies. So, for example, peyote has been used in a lot of kind of tribal religious ceremonies, but there are also other examples historically of use of things like magic mushrooms or the psilocybin to kind of enhance what somebody believes they're experiencing in a religious sort of way. There's also been some really interesting work about what's known as microdosing of substances like LSD. And so it's giving an individual LSD at such a low amount that they're not experiencing any sort of hallucinations, but the sort of microdosing of the LSD to treat things like PTSD. Um, it I think it's still largely in clinical trials, and there are always positives and negatives associated with any sort of these pharmacological uses of drugs. But there are some of those interesting studies about the use of hallucinogens to actually help treat some psychological disorders. Question: why are some people more susceptible to addiction when trying a drug? Yeah, that's a very good question. Um, I don't know the mechanism for addiction. I mean, there's going to be a genetic component. There's going to be an environmental component. Um, I don't know if somebody who is more susceptible, for example, to alcoholism is more susceptible to addiction across the board. I mean, that's certainly how it's talked about colloquially in the public eye, but um, there is evidence to suggest that um, addiction dependency is passed down at least to some degree genetically. So, for example, alcoholism tends to be passed down on the paternal side, and it tends to skip a generation. So, for example, if your grandfather was an alcoholic, um, it seems to not necessarily be the case that your father would be more likely to be an alcoholic, although there may be a slight increase, but it is more likely that you would become an alcoholic. Um, and so there is that substantial genetic component, but I don't actually know what makes some people more susceptible to addiction than others. It also may be the tie to um, kind of the experience of that substance, right? And so some people just tend to have a higher level of tolerance in general to drugs, and so it may be that those who have lower levels of tolerance at low levels of use can get this kind of habit forming behavior because of the kind of chase of that high after they initially experience it. But I don't actually know the answer to that question. It's a really good question. Any other questions? All right, if others come up, please send them. All right, so we talked about stimulants, we talked about hallucinogens, and now the flip side of stimulants is the depressants. And so depressants are any of these psychoactive substances that cause a depression of the central nervous system, right? And so whereas stimulants created an activation of the CNS, depressants are depressing the activation of the CNS, right? And so it's critically important to remember that depressants don't necessarily make you depressed. They are just slowing the functioning, of your central nervous system. And so somebody type into the chat box, what would the depression of your CNS mean in terms of a physical response? What changes in your body would occur? Yeah, exactly. So lowered heart rate. Yeah, it's a great example. And so um, the lowering of the heart rate is actually one of the issues associated with overdosing on things like opiates that we'll talk about in just a minute. But yeah, any depressant is going to kind of lower your heart rate, lower your respiration, drop your blood pressure, etc. And this is why things like alcohol, which is a depressant, tend to have kind of a relaxing effect in low doses, on people because it is depressing that sort of nervous system activity that may otherwise be somewhat elevated. And so, oopsies, did we skip over that? No. And so, like I said, an example of a depressant would be alcohol. One of the issues with alcohol can be this sort of potentiation effect. And potentiation is wherein you get the combination of two drugs wherein the total effect is greater than either of those substances by themselves, right? And so you may have had prescription drugs at some point wherein it says do not consume with alcohol. And that's because they're concerned about these potentiation effects, right? These interactions wherein taking with alcohol is going to either enhance or present symptoms that you weren't otherwise expecting, right? And so it could be that you get certain levels of delirium or confusion or sleepiness, etc. And this potentiation can prove fatal, especially in specific depressants, right? And so on some drugs, you can have sort of mild interaction effects, but on other drugs, drinking alcohol while on that prescription can lower your heart rate, lower your respiration potentially to such a low level that you can actually die from that sort of interaction. But one of the other side effects of long-term heavy alcohol use is substantial brain damage, right? And so it's not just necessarily the case. You may have heard growing up, don't drink while your brain is developing. And that is absolutely true. But even after your brain has developed, you can have these long-term, permanent, and frequently severe brain damage issues that we'll show you some MRI scans in just a minute. But even in the moment of alcohol abuse, you can get issues of dementia, right? This complete confusion, lack of awareness, blackouts, seizures. You can also get, in certain cases, hallucinations and damage to peripheral parts of your nervous system. And so here is one MRI scan of what a normal brain looks like. You can see the actual volume of the brain of a normal 43-year-old. And then on the right-hand side, you have the brain of an alcoholic. And you can see substantial reductions in the actual volume of this individual's brain, right? And the volume of your brain directly corresponds to essentially the computing power of your brain, right? And so think about your brain as an actual computer. Here is your stock computer. Everything's good to go. Here's your computer you've opened up and taken out a substantial amount of the processing capability, of the memory, of the RAM, etc. On the top here, you have the brain of a normal elderly person. I don't know what distinction they're using for elderly. Whoopsies. In the middle here, you have the brain of somebody with Alzheimer's, right? And so you can see up here even some kind of deterioration, but on this lower hemisphere down here, you can see substantial deterioration. And think about how debilitating Alzheimer's can be, right? Somebody with Alzheimer's can't really function in their environment without substantial assistance as that disease progresses. And then look at the bottom here, right? And so this is the brain of somebody with severe alcoholism, right? And you can see the remarkable deterioration of the brain, right? It's a shriveled, kind of bare representation of what the brain of a normal, healthy individual is. And all of these volume losses do represent losses in actual ability to function. And while this is an extreme example, you do see certain cases wherein alcoholics who have been alcoholics for a long time have marked decreases in everything from motor functioning to speech patterns, to memory, etc. Right? And so it's not just a temporary issue you're causing with substantial alcohol use, but there is long-term lasting effects on your brain. Right? And these aren't MRI scans, these are actual brains of patients. And so two of the most common issues with alcohol abuse for um, the individual using it are Wernicke's disease and Korsakoff's syndrome. And so there's also issues with things like fetal alcohol syndrome, which is separate. It's the pregnant mother's use of alcohol during pregnancy, but these are for the actual individual consuming that alcohol. And so Wernicke's disease, as we've talked about before, Wernicke's area is, sorry about the dogs, involved in speech itself. And so Wernicke's disease is that form of aphasia where an individual is able to produce language but has lost that ability to comprehend, right? And so sustained levels of drinking can lead to the development of essentially this disorder where you can't comprehend language. And so you become essentially, to some degree, non-functioning, at least in social interactions, because you can't understand what other people are saying, right? And it's not just under the influence of alcohol, but it is this permanent brain damage associated with that heavy use. The second is this Korsakoff's syndrome, which is the development of dementia. You're developing both retrograde and anterograde. So again, forgetting the old and forgetting new things, or not being able to consolidate new memories, which leads to that inability to remember recent events or learn new information, right? And so one of the issues with heavy alcohol use in the moment is memory loss, blacking out, etc. But sustained alcohol use can lead to the development of this Korsakoff syndrome, where you are essentially kind of almost in this permanent blackout, wherein you're not able to consolidate these new memories, right? And so it's kind of, for a lack of better comparison, kind of this 51st state scenario wherein you can't consolidate new memories, you can't remember what just happened, you can't remember new things that are going on in your life, and you're also losing the memory of things in recent years, right? You may be able to still recall things from your childhood, but there is substantial deficit in the retrieval of memories from recent years past. All right, so I'm going to pause real quick if anybody has any questions about what we just talked about. Or anything else so far, stimulant use, hallucinogens, alcohol. All right, if you're typing up something, go ahead and finish typing that up. We're not going to watch this video, but I would highly recommend you watch. I think it's about a 15-minute short expose done by the BBC on opiate use. One of the issues with opiate use is not only how highly addictive it is, but the issues associated with overdosing, right? And that's why you have so many deaths per year from opiate use, because of its depressant nature, right? So really high levels of use of something like heroin reduces or slows your central nervous system activity to a point where you'll stop breathing, right? And so There have been attempts to develop essentially pharmacological remedies to this. And so you may have heard of the drug called Narcan. And so Narcan, if delivered in appropriate time, and there's a short window where you can deliver it, will actually block the essentially your brain's processing of that opiate to bring somebody back to consciousness and back to life. It's a really remarkable drug, and you can actually find videos online of people who are using Narcan on a patient, sometimes in police interactions, but also sometimes home videos of these things. And it is a really, really remarkable drug, and how quickly it turns somebody around. But again, there's this very short window wherein if Narcan isn't administered in an appropriate amount of time, that depression of the central nervous system activity can lead to cessation of respiration, but also slowing of the heart such that the heart actually stops. And you'll actually see, it is a fairly graphic documentary that does show some heroin users, but you'll get to see, what somebody who is high on heroin actually looks like, right? And it is, it's kind of hard to describe. I mean, it almost seems as though they're just kind of going to sleep. They get into this kind of depressed trance wherein nothing really stimulates them from the outside world. So I would highly encourage you watch this to just get an idea of what that actually looks like. What is the kind of the scope of the abuse? And this is one of the reasons why the overprescription of painkillers is such an issue, specifically in the U.S., because it's kind of this habit-forming drug wherein somebody will get prescribed some sort of painkiller by a doctor for legitimate use. And then they kind of develop this dependency on that prescription. They get to a point where either they are told they can't be prescribed anymore, right? The doctor will stop prescribing them, or they'll realize that it is cheaper and transition to use of things like heroin. I don't have the addiction numbers right in front of me, but a shocking percentage of people who use opiates for over 2 weeks become addicted to some degree, right? And this is because of the nature of prescriptions leading to that addiction. It kind of transcends socioeconomic boundaries that normally exist within various drug use. And so you do get people from all walks of life who become dependent, highly dependent on these opiates, like painkillers, prescription painkillers, or heroin, for example. All right. So just finally here, another question came in. Can people really get addicted to sugar? If so, does it act as a stimulant? Yeah, it's a really good question. So yeah, people actually can become addicted to sugar. If you look at patterns of brain activation for people who are, kind of highly psychologically addicted to things like sugar, there are very similar brain activation patterns to those who are using things like cocaine. That's not to say sugar is as addictive as cocaine, but there is absolutely kind of this psychological dependence, and sometimes even physiological dependence. You'll see kind of physiological responses to people who have a high sugar diet coming off of that high sugar diet. As far as it's acting as a stimulant, that's a hard question, right? Because there are clearly certain aspects of sugar that lead to activation of the central nervous system, but not to the degree that actual other stimulants do, right? I'm not sure you could actually give yourself a heart attack by eating, a pound of sugar. You may give yourself diabetes, and you may have, other physiological responses to eating that much sugar. But I don't think it operates in the same way as typical stimulants. And in fact, one of the biggest misnomers about sugar is kind of this sugar high, right? And so there's actually nothing within sugar that should give this kind of hyperness that you see in kids. It's frequently just the case that you're getting this increased level of hyperness because increased consumption of sugar does lead or does correlate with other kind of abnormal life events, right? Parties or gatherings or things like that. That being said, there are also other consequences of sugar use. So inflammation, which has also been correlated with anxiety and depression, things like that. So yeah, you absolutely can get addicted to sugar. I don't think it necessarily acts as a stimulant, at least in the typical sense. But yeah, there are absolutely psychological dependencies on sugar. Good question. All right, so finally in here, it's important to know that there are all sorts of influences on addiction, right? We've talked about some of the biological influences, right? Perhaps genetic influences on addiction. There are the psychological influences on addiction, right? Self-medication, but also kind of the development of dependency on things like, for example, marijuana. To go back to that example, one of the things I saw a lot in Colorado was people, claiming they couldn't go throughout their day without smoking, right? They would smoke before work, they would smoke before they would drive. And in any other context, that is an obvious example of addiction, right? Somebody who drinks before work, somebody who drinks before they drive is obviously an addict. And so there has, kind of been this debate around the addiction of marijuana because there's no physiological dependence. People think that, okay, abuse of it doesn't represent addiction. But there is absolutely that sort of psychological dependence on various drugs. But there's also the social influence, right? And so social norms can encourage people to take drugs in order to fit in with their peers to look cool, which can result in actual dependence and addiction on these drugs. That's why there's such big efforts in college communities to try to reframe the perspective as to what you should be doing on a Friday night, right? So a lot of colleges try to combat this excessive drinking culture, right? For those who are over 21 and who drink in moderation, there's nothing wrong with having a drink every now and then, but trying to change these sort of social norms to prevent the substantial negative consequences associated with drug and alcohol abuse, right? So having those social norms can change the overall cultural behaviors, individual behaviors, etc. So I'm going to pause real quick. Does anybody have any other questions about what we covered today? All right, I am not seeing any other questions come through. So what I'm going to go ahead and do is in class, but I would ask that if you haven't already completed your SIE for this class, please go ahead and do so. Again, it helps me, it helps the university. It's a big thing that's considered when I go up for tenure in a few years. And so I would ask that you all spend the next, we have 25-ish minutes until the formal end of class. You go fill that out, please. I'm going to stick around and answer any questions that folks have, and I'll hang out here until everybody signs off. But please go do that. And then next time will be our last lecture of the semester, and it'll be about human factors, my specialty. So it will obviously be the best lecture, right? We've saved the best for last. We've saved the most interesting thing for last. And then we will start getting you ready for final exam. And then also let me finally say, I know that final exam time is a uniquely stressful time in general. It's probably going to be additionally stressful given the impacts of the coronavirus and everything else that's been going on. Please reach out to me if I can do anything to help, not just necessarily in this class, but if you just need somebody to talk to about kind of all the stress associated with what's going on and how that may be interacting with finals, etc. So please do reach out to me if there's anything I can do for you as we get towards the end of the semester. I want to be there for you. I wish I could be in person and we could meet, but you know how to get a hold of me and we can take care of everything. So without further ado, if you have any questions, stick around and I'll answer them. Otherwise, please go fill out those SIEs and I will see y'all on Thursday. Madigan asked, when determining whether or not someone has a substance use disorder, is time a factor, amount of time a substance is abused, or is it strictly the level of abuse? That's a really good question. Again, this is well outside my domain of expertise. Like I could not diagnose somebody with a substance use disorder. Time, I suspect, has some sort of influence in the sense that somebody who abuses alcohol once is probably not said to be an addict, but if there's a pattern of abuse, which would be inherently reliant on time to some degree, that would be a good indication of abuse. And so it's the interaction of time and it is that level as well. Good question. Are sleeping pills potentially as addictive as alcohol? Yeah, absolutely. So there are, you can kind of think of sleeping medications in two different broad categories, right? Habit forming and non-habit forming. So habit forming would be those that you develop a physiological dependency on, such that when you take them, they help you go to sleep. But if you stop taking them, you have kind of this backlash where you can't sleep, not just the normal levels of perhaps insomnia, but substantial backlash. And so they can become very addictive in that regard. There are non-habit forming types of sleep medication. So things like melatonin are just attempting to mimic what your brain's already producing. They may be habit forming to a lesser degree, but there are other non-habit forming pharmacological options for that. So it depends on what type of sleep medication we're talking about, but they could be potentially as addictive. They're probably not abused in the same degree because their purpose is to put you to sleep rather than to give you any sort of relaxation. So they probably won't be abused in the same manner that alcohol would be abused, but they still are potential drugs of abuse. Good question. What's the difference between depressants and antidepressants? Yeah. So again, don't think of depressants as the psychological depress. It's the actual depressing of your central nervous system. It's the slowing of your nervous system. So when we talk about depressants as a drug, think of it as kind of a slowing drug, right? So alcohol is a slowing drug. It slows your heart rate. It slows your respiration. Opiates are a slowing drug. They're slowing your heart, slowing your respiration. Antidepressants are drugs that are trying to combat the psychological instances of depression, right? So in this case, antidepressant is referring to kind of the psychological phenomena of depression. And so antidepressants in that case would be pharmacological responses or attempts to change the chemical imbalance in one's brain to help combat depression. And so it's not like taking an antidepressant and then a depressant drug will have counteracting effects, because in this case, depressant drugs are just the depressing of your system rather than the psychological depression. Does that make sense? Good. Yeah, it's a really good question. It's definitely one of those areas that trips up a lot of people. You too. Colton, Sophie, or Bruti, do you have any questions at this point? All right. I'm not hearing from y'all, so I'm going to assume radio silence means y'all have no questions. But if anything comes up, please do shoot me an email, and I'm happy to meet.